Hello friends, this is a case of robotic radical hysterectomy for cervical cancer, and we are starting the procedure with the draping of the Da Vinci robot, and after that these are the instrument arm which is draped, and following the instrument arm drap, this is the now the camera arm drap is going on, and all the arm is draped. After that we have put here the instrument, that is grasper, seizures and bipolar, Maryland and needle holder. Now this is the calibration of the telescope is going on, and as we know that 3D calibration and the white balancing is important, just like laparoscopy before starting robotic surgery. So these all are over. After that, here we are using the telescope for the supraumbilical, and then bilateral ipsilateral port we will use. So this is the camera calibration and white balancing is done, and we can see both the cross are over each other. There should not be two plus sign, there should be one single plus, that means calibration is complete. 0 or 30° both you can use for calibration, however here we will use the 30° telescope. So now all the ports and docking is complete. Here initially there was some adhesion, so initial adhesiolysis is being performed, which we can see that anterior abdominal wall, some of the omentum adhesion was removed due to the previous surgery, and after that we will start the hysterectomy. So this is just the adhesiolysis of the omentum was there, and this patient is a 55-year-old female with the cervical cancer, and what we have to remove is the uterus, cervix, upper third of vagina and the lymph nodes also, parametrium also. So lymph node dissection will start from the left side of the iliac and obturator group of the lymph node. So after these all adhesion which is removed, now the lymphadenectomy will start. So we can see here that left hand has a grasper and right hand has a seizures, and we have a 2 ipsilateral port and 1 contralateral. Here we can see some adhesion with the omentum over the uterus posterior wall is there, that is through the rectum, that adhesion also was removed, and uterus looks good. However, there is a posterior wall fibroid, but that is anyway going out with the uterus. So everything is fine, there is no endometriosis, there is no any frozen pelvis, there is no any adnexal pathology, and all looks normal. So this patient has already been proved of a cervical cancer. So we will start from the left side of the dissection, and this is the left triangle of dome, and just in between the round ligament and the IP ligament, this is the dissection, and these all cellulolymphatic tissue will be removed first on the left side all around the iliac vessel. So we can see external iliac artery is visible in front, and the medial to external iliac artery, external iliac vein is also visible. These are some oozing which is getting stopped by the monopolar seizures. And now this is the cellulolymphatic tissue dissection. This is lateral to the iliac vessel start. The lateral most margin for these surgeries are the obturator nerve, and that will be lateral to the external iliac artery. So these all cellulolymphatic tissue has to be removed, and because there will be hidden lymphatics there, and it should be all around the iliac vessel. These type of little oozing you can touch with the bipolar open jaw of the bipolar grasper and it will stop. So we should take care that we should do as much as possible unblock dissection. So, this is the medial to the external iliac vein. You can see this blue color external iliac vein is visible, and once you go deep in this medial plane, then obturator area will be found, and you can see the pectineal ligament also will be visible. So, we can see now this is the lighthouse visible, and here medially medial umbilical ligament is visible, and medial to that is the paraphysical area. So, these all cellulolymphatic tissue of this area has to be taken out. So, we can see this is the IP ligament, and most medial structure what we have to identify is the ureter, that is the most medial structure of the pelvis, and you can see the pulsation of the external iliac artery is visible in front, and medial to that is external iliac vein, and here this is the in between the external iliac artery and vein, and here is the ureter, most medial. So, after removal of those cellulolymphatic tissue, we have to keep it in such a proper place that we should not miss it, and it should be visible, it should not go to the coil of intestine. In many of the situation, it is better to always keep a endo bag and drop these tissue inside the endo bag, so that it should not get this misplaced. Intraoperative projection and serial sampling is also good in some of the cases, but here we will collect all of them, level it, and then it should be taken out. Now, we can see here that little suction irrigation is done just to remove this little oozing which is on this tissue, and here is the internal iliac, and we are in this area of the, this is latjo space, and this is the lateral to the ureter, and we can see internal iliac, and the first anterior branch of the internal iliac will be the uterine artery which will be visible. So, this is the internal iliac, and here is the junction of the ureter is the most medial structure, and we can see this is the first anterior branch, that is the uterine artery. Now this suction irrigation is keeping the ureter pushed medially, and this is assistant is applying the hemolog for the uterine artery. And as we know that it is important in radical hysterectomy to apply the hemolog near the origin of the uterine artery, and near the origin of the uterine artery it is very thin, so it is easy to secure. Even ligation directly you can seal it, but just for the precaution we have applied hemolog and one titanium clip above, and then it will be cut in between this titanium clip and hemolog. Now above the uterine artery, the area which is there, that is called paravesical, and below the uterine artery, that area is called pararectal, and medial to the ureter is lacho space, and medial to ureter is the Okabayashi space, and lateral to the lateral space. So here we can see this is the posterior leaf of the broad ligament which is getting open, and slowly because you have to remove all the parametrium tissue also. So it is important that you should open the posterior leaf, and you know posterior, this is the IP ligament, and here that was hemolock was applied, and this is the ureter, that is we can see peristalsis of ureter is visible, that is the most medial structure in the pelvis, and just this is the Okabayashi space, and here is the posterior leaf of the broad ligament, and that is the ureter is getting little lateralized, and this peritoneum posterior leaf also will be cut out. So we can see now the right side will start the dissection, again in between the round ligament and the IP ligament peritoneal incision will be given, and that will start from the deep ring extending parallel to the iliac vessel up to the IP ligament, and similar to the left side, right side of the cello-lymphatic tissue of the iliac and obturator area will be removed. So we can see external iliac started visible, and then lateral to the external iliac all these yellow tissue, that is however in this patient we are not using ICG, but nowadays if you will inject the ICG on the cervix at 6 and 12 o'clock position, then these type of cello-lymphatic tissue will take the dye due to the lymphatic, and it will be very easy to separate those tissue in the under vision of the CSF mode or the ENV mode of the ICG. And the Da Vinci Firefly has a very good ICG recognition, that is for the perfusion as well as lymphatic as well as for the vessel, all purpose it can be used. So similar to the left side, this is the cello-lymphatic tissue of the right side is going on, and it should come as a chain as a en bloc dissection, and more you will make it all around, that will be better, and piecemeal necrosis should be avoided. Now this dissection is started medial to the iliac vessel, and here we can see internal iliac will be visible, and then the most medial structure ureter also will be visible. And these cellular-lymphatic tissue again we have to keep in the right iliac fossa carefully, and here is the ureter, that is the most medial structure. Right side of the ureter crosses external iliac vessel and left side of ureter is crossing the common iliac vessel. So, ureter is medialized and this is again the area of the lattice space, and internal iliac is visible in front. So, these all cellular-lymphatic tissue in the pararectal area also has to be nicely separated. Again here we can see this is reaching up to the pectineal ligament of the right side, and this will be visible. And these all cellular-lymphatic tissue will be removed out. Obturator area will be cleared. This is just little oozing that we can touch with the bipolar. So, it is a combination of the electrosurgical dissection as well as sharp dissection with the seizures as well as blunt dissection. At that time seizure also act as a spatula to do the blunt dissection. So, these all cellular-lymphatic tissue again it is kept over the cecum, and that should be taken care of, that it should not displace. And now again further pararectal dissection will start, and as we can see this is the posterior leaf of the broad ligament, and just below we can see ureter. If you see peristalsis of ureter is also visible through the peritoneum. Now this is the IP ligament and that will be clipped and cut. So you can see this is the hemolock which is applied on the, and then it will be separated. So from here the ovarian artery also goes to the ovary. So however with the ligature you can seal it, but it is better to clip that there will be no any bleeding. And below the IP ligament you can see through the peritoneum ureter is visible. Assistant is cutting it with the harmonic. However, in robotic also harmonic is present, but here we are not using robotic harmonic. Now this is the most medial, you can see ureter, and just this is lateral to ureter, again this is latgo space. Latgo, latco and latjo, both the people are pronouncing it. So generally I feel easy to latjo space to tell. So here we can see this is the first branch, that is uterine artery is visible, and above the uterine artery the area is paravesical, below is the pararectal, and this is the first anterior branch of the uterine internal iliac, and this is uterine is getting applied the hemolock, and suction is keeping the ureter pushed medially. So this latjo space is nicely opened, and the only structure which crosses at right angle to this space is uterine artery, and above the uterine artery all the area is paravesical, below the uterine artery is pararectal, medial to ureter is Okabayashi space, and lateral to ureter is latjo space, and in medial area you have the medial Okabayashi space, you have the hypogastric nerve plexuses, and in the latjo space you have the, this is the uterine artery getting coagulated by the harmonic. So this part is over. Now we can see again this is ureter in front, and now to cut the posterior you have to go to the ureteric tunnel, to go you have to little bit medialize the, lateralize the ureter, and this is the peritoneum just parallel to the ureter, and you can go parallel and push, parallel and push, and here ureter is dropping down, and this area of the peritoneum is getting separated, and ureter is down, you can see peristalsis of ureter is visible, and here this uterine artery is anterior to ureter and vein will be posterior to the ureter. So this is important to keep in mind, and either side of the ureter all the cellular-lymphatic tissue you have to separate. So now this posterior leaf of the broad ligament is further excised to take the parametrium together, and it will reach up to the cervix on the right side. Here we can see this is a cesarean section before. So bladder is adhered. So bladder can be gently separated, and always take care that during the separation of the bladder we should get to the white areolar tissue plane, and then take care that fat belongs to bladder. So it should be, we should be below the fat. Here We have to remove the upper one third of vagina also, and in this patient we could not put the uterine manipulator and colpotomizer. So, we have just used a sponge to push the cervix. So, upper one third of vagina also has to cut out. So, this is just above the rectum, this is the posterior cul-de-sac peritoneum which is getting cut. In the Da Vinci, one of the biggest advantages is that you have the 3D vision. So, vision is relatively very good compared to laparoscopy. So, your dissection, and there is a tremor filter and the motion scaling, all these will make this surgery easy compared to the laparoscopy and even compared to open surgery. So, we can see this is the uterosacral ligament which has to cut completely. So, this is a posterior marking is given that that much vagina will be removed, below is the rectum. Now, anterior dissection will be done and the bladder should be separated. So, right side you can see all the structures are visible, and this is again the right side. Anterior leaf of the broad ligament is cut, including parametrium which will be excised. Now, this is the UV fold peritoneum, and slowly the bladder is getting separated, so that at least 3 centimeter of the upper vagina also will be removed. During that separation, we have to take care that it should be a combination of the sharp as well as blunt dissection, and we should take care that fat should be always remain with the bladder, because fat belongs to bladder. You can see the uterine is visible here, and as you know, uterine always look like a leech. So, this appearance of uterine is visible. However, It is already separated from the internal iliac at the place of the origin. So, you do not have to coagulate at this place. Here assistant is trying to push the cervix inside with a sponge of a size of a table tennis ball and pushing into the sponge. He is pushing it in, so that this dissection of the bladder will be easy. We can see here the internal iliac and the uterine branch is visible, and this is the bladder getting separated from the anterior vagina. You can see the ascending uterine is also visible here over the uterus, and this assistant is again pushing the sponge in the sponge holding forceps, pushing the cervix inside, and that will help you to dissect the bladder. So, we can see slowly bladder is going up and always remain below the fat, because fat belongs to bladder. Now, this is the vagina, which you can see the crisscross pattern of the vessel over the pearly white vaginal fascia. So, left angle of the vagina sometime is good to coagulate. And this bladder is on the left side is separating. So, now this side of the separation of the bladder is almost complete, and upper third of the vagina is free from the bladder. We can see now this sponge which is pushed through the vagina is visible, and this is anterior colpotomy is being carried out. So, we can see clearly this sponge is visible, and this is the right side of dissection. Little bit on the angle of the vaginal artery will be there on the lateral margin. So, this is better to coagulate with the bipolar before cutting, otherwise it bleeds. Ureter is below most medial peristalsis of ureter, you can see, which is dropped on the floor, and this is posterior colpotomy which is going on. And now upper one third of vagina is also removed. After this sponge is removed, and the uterus will be taken out by the assistant through the vagina. This is Ehlers forceps. Claw forceps also can be used to remove it. Of course, shortening of the vagina will happen, but in these surgeries, because these are life saving surgery, shortening of the vagina is not considered as a big problem. Now, this assistant is taking with the finger in the vagina, all these lymph node is taking out carefully. Gas, to prevent gas leak, there is a sponge in the gloves which is packed in the vagina, and by the side of this gloves finger should come. You may use a stone holding forceps, but holding the this fatty cellulolymphatic tissue by finger is easy. So, that is why finger is used here to take it out clearly out. So, now this all the cellulolymphatic tissue is out, and then suture will be introduced, and the closure of the valve will be initiated. Here, for closure of the valve was done by barb suture. So, now the right side of the scissors will be removed, and the barb suture can be pushed through the vagina itself. Here you can see the gloves, and there is a sponge inside the gloves has a benefit that it will keep it distended and the gas will not leak. So, this is the barb suture which was pushed by the side port by the assistant through the directly through the wound, and now the closure of the vault will start. So, while closure, because it is a contralateral port, so anterior vagina will be taken first, full thickness, then the posterior vagina, angles also will be taken, and you should be careful that vaginal epithelium should must be included in the bite. And as we know in the barb suture, it is unidirectional and there is a loop in the beginning of the suture. So, you do not have to worry, you can just pass the needle through the loop and then it will lock. If you are not using the barb, and then you can use Dundee jamming knot, continuous suturing and Aberdeen termination by simple vicryl as well. So, this is a starter knot is done, and now continuous suturing you can continue from one side to another. It can be locked also every time, or you can do two layer also, and French surgeons generally they use the extracorporeal square knot with the Clark knot pusher for the walled closure. So, this is the personal choice. So, here continuous suturing is carried out for the closure of the vault. Vaginal epithelium inclusion is necessary in this closure, as I am always telling, even in the total laparoscopic hysterectomy, not including the epithelium will create granulation tissue formation and a spotting will be there, bleeding also can happen for many months. So, epithelium should must be included, and care should be taken that the bladder should not be pricked, because of the shortening of the vagina. You have very less vaginal age to do this suturing. So, slowly this continuous suture is carried out and we are reaching up to the left corner of the vagina. It was locked every time after taking the bite, so it will be completely airtight closure. So, now it is over, and then the suture will be taken out carefully with the needle and a drain will be introduced. Suction irrigation should be performed just to check out some bleeding, and a drain will be kept inside the pelvis. So, thank you very much for watching this video. Have a nice day, and I also wish you a very happy new year 2026. So, thank you.